Sorry, good afternoon and a warm welcome to our session this afternoon. So we have moved on to our session on trauma and rehabilitation, and we have 8 presentations of 5 minutes followed by 2 minutes of questions. In the interest of time, can I invite the speakers to come and sit at the front? Thank you. And can we invite our first speaker up, please? And we have James Tomlinson presenting on TLIX, reliable in the hands of pre-registrar clinicians. Thank you.
Thank you. Afternoon, everyone. I'm James Tomlinson. I'm a spinal surgeon in Sheffield. This work was mostly not done by me. It was mostly done by our trainees, actually, but none of them are here. They're doing fun things, so I've been offered the opportunity to come and present this. Most of you will know what this is, but why did we do this? Because we are seeing a tidal wave of referrals. We're a tertiary centre surrounded by district hospitals, and the workload to our registrars on call is just going through the roof of every single patient that comes in the door of a surrounding hospital. Without being too rude about colleagues, some of the referrals are not far off. This patient has a spine, what shall we do? And they quite rightly have pushed back and said, we do not have the capacity when we're dealing with all the things that come into our own department to be replying every 20 minutes to what do we do about this, that and the other from every ED around the region. So part of the logic here was, can we find ways to stop that workload? This is one possibility. I don't think it's maybe the solution, but I suppose it's about starting that conversation. For anyone who doesn't know what TLIX is, I'd argue a lot of spinal surgeons don't use it for reasons we can come to, but it's a scoring system. It's designed to guide management of spine fractures, and it looks at 3 key things: the morphology of the fracture and the fracture type, whether the posterior ligamentous complex is intact, and the neurological status of the patient. If coming at it from an orthopedic viewpoint, what's its flaw as a classification system? It tells you to not operate on the ones you didn't think you were going to operate on. It tells you to operate on the ones that you thought you probably needed to operate on. And it tells you it isn't sure what to do with the ones you weren't sure about. And what's the goal of a good classification system to help all of us decide what to do with the patients we're not sure about? How did we do it? We took most of these referrals, rightly or wrongly, come from people working below registrar levels. Some of those are AMP, some of them are foundation doctors, some of them are core trainees. So we excluded registrars from this study deliberately. We took all of the injuries that we'd been referred from surrounding hospitals over a 3-month period, and we made PowerPoint slides. So each case, which I'll show you in a second, you get a PowerPoint slide with the details of the case. And then we looked at basically the reliability and agreeability between raters. So this is an example case. There is a flaw here that what they don't get is the whole of the CT to scroll through all of the axials, all of the sagittals, and all of the coronals. So they get selected slices on a PowerPoint along with some information about the patient's neurological status. Why did we do it that way? It was just going to get really messy and very difficult to start sending scans to all the different centres these people were in. So this was about pragmatic timescales, really. And then for anyone who's not familiar, Landis and Cock criteria of Fleiss Kappa, which is the way we interpreted this data, is just really about how do the raters, in this study 20 of them, agree with one another, and that goes from poor agreement to almost perfect. In terms of overall, so this is the how reliable are people at saying, I think this fracture is less than 4, doesn't need surgery, it's a 4 and I don't know, so maybe I need some advice, or it's a 4, it's more than 4, so this definitely needs an operation and it needs to go to a regional centre. Moderate reliability, and I guess the question I'd ask to all of you is, if you're a patient and someone turns up at the end of your bed and says, I'm moderately sure I know what to do with your spine fracture, would you feel reassured that that person was going to treat you safely and reliably and you can trust them? I'm sure most of you would think, no, I don't feel particularly comfortable that you're moderately sure what to do. Fracture morphology, actually reliability is quite poor. So actually, are the people we asked here able to look at these scans and work out, is this essentially a high or low energy fracture, and what type of fracture is it? No, they're not, very predictably. Neurology, very good reliability. I think in this case, obviously, these are PowerPoint slides. So the neurology was this patient has the following neurological deficit or normal neurology. So I would actually argue you'd expect perfect agreement here that we had to pretty much say what the neurology was and whether there was a deficit because they couldn't examine the patient. And then again, is the posterior column intact or potentially compromised? Fair reliability. And again, I'd argue if someone came to me as a patient and said, I'm kind of got fair sureness that I think I know what to do with your injury, I'd feel quite nervous. So it's not great, is the honest answer. We have done some previous work with this in the hands of non-spinal surgery consultants and showed actually the reliability in consultant hands is much better. And we also did some further work with that group, and they reported that they found this tool quite useful because it gave them a strategic approach how to think about these injuries rather than just going, it's a spine fracture and I don't know what to do. But I think we would argue this doesn't appear to be reliable in the hands of the people we sent it to, and ultimately these are the people who are seeing these patients and trying to work out what to do with them.
Just final remarks, please.
No problem. So we would advocate, I think this is the key, we would argue that senior orthopaedic consultants, because that's where most of these patients are being looked after, need to be involved in the care of these patients early because the people seeing them first off the bat don't really know what to do. But this model may have a role as an educational tool if it's used longitudinally to at least give people a structured approach to assessing these injuries. Thank you.
Thank you very much. Let's open for any questions.
Hi, the obvious one would be you excluded registrars from this study.
Yes.
And you suddenly jumped a grade and went to consultants who are non-spinal. But what about using orthopedic registrars and their
we did a study a few years ago looking at non-spine consultants just to see, would it work?
Did you run the same cohort?
So the reason we didn't do this with registrars is certainly in our region, when you're on call as a reg, you're in theatre pretty much all day and at night you're at home. So you're either not available because you're operating to give input or you're not available because you're asleep. And the reality of a lot of these cases is they don't get discussed with the registrar. They just get sent straight to us from a junior doctor for an opinion. And there's another discussion there about, well, is that appropriate and should someone senior be available? I totally get. And I suppose that's part of this discussion is how do you decrease this burden? Because I don't think this is the right method.
Yeah, agree.
Any other question? Thank you very much.
Thank you.
So we move on to our next paper from Leon Wood, Association of Exercise Adherence with Pain and Function in People with Chronic Non-Specific Back Pain, a systematic review.
Thank you. So I'm presenting this work on behalf of a team that's multinational, so I'll talk about that a little bit more. These are my conflicts of interest. So chronic low back pain, as you all know, is a leading cause of disability worldwide, and exercise is the most commonly used treatment for low back pain. Now, when we look at outcomes for back pain, pain and physical function are the most commonly used ones, but it came to light in a realist review we undertook that actually we weren't sure what the association of adherence to these exercises we prescribe as physiotherapists and the outcomes of pain and physical function were. So the aim of this review was to try and understand if there was a relationship between pain and physical function and actually doing the exercises we prescribe to our patients with chronic low back pain. So we did a secondary analysis of the latest collaborative Cochrane systematic review, which is a network meta-analysis hopefully to be published this year. Our protocol was reviewed and approved by their Back Evidence Collaboration Steering Committee, and we prospectively registered our protocol on Prospero, as well as on the Open Science Framework. And as I said, this was an international team collaboration between Canada, England, and Australia. And how we defined adherence, we were hopeful that we'd be able to take this sample that we would get and have a look at objective measures such as pedometers or accelerometers and try and see whether we could objectively measure adherence compared to subjective records such as self-report diaries and then obviously attendance records. And we used Dan Bailey's work to classify the levels of adherence into low, which was less than 59%, moderate, 60 to 79%, and then high, being more than 80%. There were 456 trials in the updated Cochrane Review, of which 104 had some mention of adherence. But of those, only 46 actually measured adherence. These included 4,227 participants. Around 2,500 were taking part in an exercise arm, and we compared only those that had a non-exercise arm for comparison. They were on average 45 years old and had baseline pain scores of 50 out of 100 and 35.6 out of 100 on a physical function score. And on average, the exercise programs were around 18 sessions over 9.5 weeks. So when you look at the 46 exercise studies that were included, you can see we only had one objective report of adherence, 9 had subjective reports, and 36 used attendance registers as a proxy for adherence. And those adherence levels were 70% with a pedometer, 89% for home exercise, and 60% for their self-reports, and 74% for the attendance reports. This is a busy slide. I don't expect you to read it all, but have a look at these red boxes. This is the top group here is the high adherence group, which shows a relatively large confidence interval, but a significant, well, not significant, but a marker favoring exercise compared to your moderate adherence group and your low adherence group. And overall, our subgroup tests were statistically significant. But what we did from a comparison, because of the 3 groups, it was quite hard to interpret and really hard to try and understand whether the high adherence group was any different to the moderate or the low adherence group. So we used the low adherence group as our reference marker and compared both the high and the moderate group to that low adherence group in a sub-analysis. And we found there was a small reduction in pain intensity of 8.99. And similarly with physical function, the effects were slightly smaller than what we saw with pain intensity, with, again, a very small reduction in physical function when we compared the high adherence group compared to the low adherence group. So what does this mean? When we look at exercise trials and chronic low back pain, adherence is really poorly reported. But adherence is likely to be a multifactorial thing, and it's quite interesting in that we see this statistically significant effect with the low adherence group as well as the high adherence group. We saw the greatest improvements in pain and physical function with those who reported high adherence, but there seems to be some possible clinically important benefit for those particularly with pain intensity. So one of the things for you as a take-home measure is how do you measure adherence when you prescribe exercise for your patients back home? And if you're a clinician or a researcher, so within our trials of low back pain and exercise, we need to really consider how we measure adherence and whether it's objective enough for this purpose. Thank you very much.
And can I invite questions, please? And perhaps while we're waiting for people to come up, I can ask one, Leanne. So I was interested in what informed your decision about the percentages needed for compliance. So, for example, 80% for high compliance.
So we used Dan Bailey's work. So Dan Bailey had done a whole PhD on looking at levels of adherence and how to define adherence. So he used those thresholds from systematic reviews of adherence. So we essentially took what he'd recommended.
Thank you. And any other questions, please? Thank you, Liam. And if I can invite our next speaker up, please, who's Suzanne McElroy, presenting on the acceptability of the structured rehabilitation and individualised exercise and education, or STRIDE programme for lumbar spinal stenosis, a multi-method study. Thank you.
Thank you. Sorry for that very long title. Hi, my name's Susie. I'm a physiotherapist at King's College Hospital, and I've just finished my PhD at King's College London. And today I'd like to discuss with you the development and acceptability testing of a rehabilitation program for patients undergoing surgery for lumbar spinal stenosis with neurogenic claudication. So I was funded by the Dunhill Medical Trust. As you all know, lumbar spinal stenosis is an extremely common degenerative condition, and it mainly affects older people. Surgery can be really effective in this patient group, but up to 40% of people report ongoing pain and walking disability, and up to 90% of people report or do not demonstrate an increase in their walking after surgery. Therefore, they're at risk of the negative consequences associated with inactivity and a spiral of decline, possibly into frailty and dependence. So rehabilitation has a potential to optimize surgical outcomes and through behavior change, improve physical activity. Yet existing programs, they lack robust evidence and theoretical underpinning. So I undertook a program of research trying to explore what the salient determinants of walking recovery were and understand their experiences. I then used these findings to co-design a rehabilitation program, and then I conducted a feasibility and acceptability study. And I'd just like to share with you the rehabilitation program that I designed and some of the findings from this feasibility study. So this is the rehabilitation program that we designed. It's called STRIDE. That stands for Structured Rehabilitation and Individualized Exercise and Education. As you'll be able to see, there are two phases. There's a pre-rehabilitation phase and a post-operative phase. So there's 3 core sessions and provided over 12 weeks before surgery and again after surgery, with a couple of optional sessions for those who might require some additional support. Each patient is provided with a pedometer and a personalised walking and exercise program. They're given a patient manual and access to videos. And at each session, we really focus on increasing walking performance, functional strength and balance, and we address their knowledge, expectations, fears and concerns about their condition and treatment. So I then conducted a single-arm feasibility and acceptability study, and this really evaluated the STRIDE's acceptability. Now, this is crucial, as an intervention that's not deemed to be acceptable can have its effectiveness undermined. And we also looked to collect some preliminary feasibility data and some maybe signals of effectiveness. So participants awaiting surgery for lumbar spinal stenosis were recruited from a single hospital, and acceptability was assessed using questionnaires and focus group data informed by the theoretical framework of acceptability. And preliminary effectiveness was collected using 6-minute walk test, mean daily step count, and self-rated questionnaires including ODI and pain, beliefs, etc. And they were collected prior to the intervention, 12 weeks post-op, and also after the pre-rehabilitation phase. So as I say, it was a small study. There's only 15 participants that were recruited, but retention rate was 80%. 2 decided against having surgery, and 1 was unable to complete the final assessment, and no serious adverse events were found to occur related to the study. So the theoretical framework of acceptability has a number of different domains. I'm not sure if you can read them on the slide there, but green is good. So the quantitative data scored a mean of 5 out of 5. So that was very good. Burden, the highest burden was related to travel to the hospital, and that's where you sort of see the slight pinky, orangey colour there. The focus group data also supported the questionnaire data, and patients really valued the supportive, personalised nature of the intervention, and they perceived it to enhance their motivation, preparation and recovery from surgery. Of course, there is room for improvement, particularly with travel required, because this was run out of the tertiary centre. Participants were suggested adding peer support groups, and so the supporting materials required refinement. And then with the outcomes, these were promising. We observed small to moderate but clinically meaningful changes after the pre-rehabilitation, with much larger changes after surgery. However, of course, there is no comparator arm, and we can hope and presume that surgery had quite an effect too. So in summary, STRIDE was highly acceptable. It positively impacted the participants' experiences of undergoing and recovering from surgery. If effective, it could really help transform outcomes and care for patients with lumbar spinal stenosis, but it does now need testing in a randomized trial. Thank you.
Thank you very much. Any question from the house? While somebody is coming, can I just ask one thing? You know, in clinical practice as a surgeon, we find it very difficult to convince patient with spinal stenosis that you carry on activity. They say pain, cycle of obesity, more pain, not do any exercise. How you manage to convince them in the prehab bit?
Well, I think, first of all, there's the really strong message about what you're doing with prehabilitation. We're not trying to convince people that this is going to cure them. We're not trying to convince them that they don't need surgery. It's to help optimize them for surgery, to get them fitter, stronger, and hopefully have a better outcome for surgery. So that message is very important. And the participants in this study, they certainly said, well, it made complete sense to them. You know, get them better, make them better. They want to have the best outcome from surgery. So for them, it made a lot of sense. But also we work with the patient, and that's where that personalised intervention is important. Rather than a generic leaflet, it's okay, well, what can you do? And how can we tailor that to you? Because they're really fearful of exacerbating their pain. They're fearful, will they do themselves harm? And so I think the personalised nature was really important about getting that buy-in and getting the confidence to undertake it.
I mean, it needs time. On a research background you manage, do you think in clinical practice, from physio point of view, there will be enough time for each patient to be given?
Well, I would argue yes, it requires additional time than what we're providing at the moment, but I would also suggest that 3 sessions of physiotherapy before surgery and again after surgery isn't a huge ask. And if it can demonstrate, and that isn't if, we don't know, it needs to be tested, but if we can demonstrate that you get better outcomes, then I would suggest that's quite a low level of intervention to get better outcomes.
Thank you. Any other question? Thank you very much. So our next speaker is impact of early versus late mobilization of functional outcome and length of stay in adults after traumatic spinal cord injury. Natalie Gray.
Hi, so I'm Natalie Gray. I'm a physiotherapist by background, and I'm also presenting an element of my PhD study, which is exploring mobilization after spinal cord injury. By mobilization, I'm talking about that first movement up against gravity. So we're talking about sitting, standing, walking, and it is a core element of rehabilitation following spinal cord injury. But the role of immobilization and the timing of when we mobilize, it is varied in this country, and it continues to cause debate. And this may have implications for patient outcomes, and it may have implications for cost efficiencies in terms of what we do. There are some studies that have been trying to explore this, but it's been difficult to reach robust conclusions due to the methodological, the practical and the ethical challenges of this topic. So this has led to be thinking of different ways of exploring it. So this study is using clinically collected data to try and answer the research question. So this is my aim, to explore the association between time of initial mobilization and outcomes of functional independence and hospital length of stay in adults with traumatic spinal cord injury, and this is individuals who have been admitted to the specialist spinal units in England. So to go through the methods, this is a database analysis, and the database that I used is the English National Spinal Cord Injury Database, the NSCID, and this is data that has been inputted over 10 years. This was following a data access agreement with NHS England, and we created a comparative analysis. So those mobilised early, which was determined as 0 to 28 days from injury, and they were compared to the groups which have been mobilised later. For the purposes of this, that's 29 to 56 days. And it also included further analysis to look at the influence of any other covariates. The sample is adults, so over 18, traumatic spinal cord injury. We included all Asia A to D. And we also looked at those with complete data at baseline and discharge. And the measures that we used, spinal cord independence measure, the SCIM, and also hospital length of stay, which actually was the time period until deemed medically fit for discharge. That gave us a sample of 1,490 in total, divided into early and late, as you can see there, 498, 992, so quite large numbers. So to go through the results, functional independence, those mobilised early had a greater mean gain in the SCIM at discharge of 31.8 versus 25.4. So that's a difference of 6.4 out of 100. This was statistically significant, and it's also been deemed as a clinically meaningful difference to patients. This was found not to be influenced by the baseline skim, by baseline Asia, or by age. Length of stay. So those mobilised earlier had a shorter length of stay, 93 days versus 126 days as a mean. That's a difference of 33 days, also statistically significant. We found that the individuals mobilised later experienced both a longer time in hospital immobilised, but also a longer period in hospital receiving mobilisation as well. So what does this mean? So potentially, the timing of mobilisation may impact patient outcomes. Early mobilisation is associated with greater gains in functional independence and shorter hospital length of stays than those who are mobilised later. There were some restrictions, so the data access agreement led to some reduced options and reduced specificity. I could only use broad grouped data and unable to evaluate very early mobilisation, such as those within 2 weeks or even within 48 hours of injury. And there are limitations in this method. It gives us some information, but this can't be overlooked, and this leads to associations rather than cause-effect. So finally, conclusions from this study. Adults with traumatic spinal cord injury who are mobilised early are leaving hospital earlier and more functionally able than those who are mobilised later. This may suggest that there's no further benefit to being immobilised beyond 28 days for most individuals with spinal cord injury. But really the recommendation would be that further investigation is needed to identify both the optimum time within that period of when mobilisation should occur, and also to look at the specific needs of the subgroups within this heterogenic population, where there may be some that benefit from particularly early or maybe even delayed mobilisation. Thank you.
Thank you. Can I invite questions, please?
Thank you. That was really nice results. I was wondering, perhaps, because obviously you looked at early mobilization or in comparison to the final independent outcome, but don't you think that perhaps there are other factors that might have influenced their final outcome? For example, perhaps those patients who needed long time to mobilize, perhaps they had other injuries, other musculoskeletal injuries. So, 4 weeks, you consider like 4 weeks as early mobilization. That's still actually a very long period of time, isn't it? So normally you'd consider like early mobilization within 2 weeks, within 1 week.
It leads to more questions than answers. I appreciate that. Yeah, certainly. Well, first, one element of it is that the individuals that go to specialist spinal units, on the whole, don't have polytrauma. We don't know, for example, what their comorbidities were. We don't know the rationale why somebody chose to mobilise early or later. There may be a specific reason. It may be more related just to the protocol of that unit that they're under. So there's many other elements within that. 4 weeks, 28 days is quite a long time. This is over 10 years, and from what I'm being led to believe that some years ago, I think 6 weeks was quite a common time to start mobilisation. We've progressed, so 2 weeks now is often the time period that we're using. So looking at that, this seems quite a late period of time. This is just what the data says. I thought it's worth sharing, but certainly there's more work we need to do to be able to really get some answers to it.
Thank you. And just one more quick question, please. Thank you.
Great presentation, Natalie. Michelle Emsley from Nottingham. I don't know if it's part of your data set, but when you're looking at the early versus late, is there any other things that you found, such as are there worse complications associated with prolonged bed rest? Because when you look at the skims, they're obviously functional, but if we're looking at kind of like impactful kind of like complications that you look within the acute setting, did that show anything? Like, is there increased HAP or?
It's a really valid point, because complications was on my aim of what I wanted to investigate. Due to various complications in how the data is collected in the database, I couldn't pull that out on this assessment. Any other studies that have included complications have consistently found those that mobilise later have more complications. And when you get, as you know, as you get more complications, then it often leads to increased length of stay. The other thing we don't have other outcomes such as quality of life measures. We haven't got patient-reported measures. We haven't established patient preference in this. So there's many other elements of this which we probably need to add in. The other one which possibly leads on from this is economic evaluation as well. So even if the outcomes are the same, is there a difference in cost of the two different models of what we do? More questions? Yeah.
Thank you. Thank you very much.
Do you think the result could be skewed because early mobilization happened for the patients who had less intensity of injury and they were able to mobilize early?
It is definitely a possibility, yeah. I mean, you have to keep that in mind. It was interesting that the two groups were compared. Between group differences was analysed. The group which were mobilised later had slightly more severity of injury, not much in it, but when we did the further regression analysis, that was not found to be a variable that impacted the outcome. But your common sense makes you think that that is likely to be part of it as well. So yeah, all these things need to be added in. But other research that has been done, it seems to be independent of that earlier still do better.
Thank you.
Thank you. And can I invite our next presenter, Chris Newton, up, please, who's presenting on breaking the cycle of persistent low back pain, health inequalities and multi-morbidity, a UK NHS cohort study of cognitive functional therapy. Thank you.
Many thank you. So I'm Chris Newton, I'm a consultant physiotherapist at University Hospitals Coventry and Warwickshire. I'm delighted to present this work that we're really passionate about, targeting health inequalities. So the local picture in Coventry is really clear, and it's no different to the national picture. There are around 50,000 people experiencing ongoing back pain, and around 30,000 have high-impact back pain. We know there are a lot of people with comorbid physical and mental health conditions, i.e. there's around 70% of people are classified as overweight or obese, 30% of people are physically inactive, and around 1 in 6 people have severe mental health illness. We see increased prevalence of back pain in areas of eye deprivation, which there are pockets of that in Coventry like everywhere else, and there's also inequitable access to care. And that results in a significant spend on MSK care, particularly where back pain accounts for around 50% of this. And as I say, this reflects the national picture. So prior to this study, I did some work as part of a PhD to evaluate whether it was feasible to deliver the complex intervention that you've heard a lot about this week, cognitive functional therapy, in an NHS setting. And what we found through that study, it was feasible to train and deliver CFT by physiotherapists who were band 6, band 7 level, and it was acceptable to both the physiotherapists and the patients. We also evaluated outcomes in 60 people up to 12 months, and we saw sustained clinical effects in terms of reductions in pain and disability, as well as amongst another raft of secondary outcomes. So taking this forward to this study, we identified a cohort similar to what you saw on that original slide. People in Coventry who were experiencing persistent back pain were able to plug this data into the local primary care network records, and we identified 72 people straight away from a small practice of 4,000 who had seen on average a GP 32 times in the last 12 months for their back pain and other health conditions. So we invited them in to test the proof of concept of treating them with CFT, but also then invited them to co-design the intervention, to adapt our materials and resources for people who would be participating in a future study. We then went back to the Integrated Care Board and asked for some more funding, of which they agreed, and then we set up a cohort study. And our eligibility criteria were people with back pain for more than 3 months, who were living in the most 20% deprived areas of Coventry. They had to have 2 or more long-term physical or mental health conditions. They had reduced workability, and they were prescribed medications that are not advocated by clinical guidelines. So what we designed was a single-centre cohort study. We invited 61 participants, and we determined that we wanted to assess the clinical outcomes, but also the healthcare utilisation costs in this cohort. For the utilisation costs, this was 13 weeks prior to the intervention, and the clinical and utilisation costs were then measured at baseline and then at 3 and 6 months, and I'm reporting the 6 months outcomes today. The self-reported clinical outcomes were disability using the Rowland-Morris, pain intensity, work absenteeism, and the patient acceptability symptom state, and healthcare utilisation costs were based on NHS tariffs, and that included a number of healthcare contacts, number of prescription medications, and we also measured health-rated quality of life using EQ-VAS. So our baseline data showed that these were a highly disabled cohort. Using the RERO questionnaire, 72 was the mean score, which tells us they were high risk. The Roland Morris was 17 out of 24, high pain intensity, and 6.6 comorbid pain sites. They also had 4.6 other long-term conditions. They'd also seen in the previous 13 weeks 6 different healthcare practitioners in primary care. 50% of the cohort were unemployed, and those who were working had lost 44 days in the previous 13 weeks because of their back pain and health problems. There was high prescription costs, and 90% of the cohort were taking opioid medications. Some reporting outcomes for 49 people at 6 months. This is work still to be evaluated, but preliminary results suggest that there were clinically significant important reductions in pain and disability. So a 5-point reduction from 17 to 12 in the Roland Morris, 2-point reduction in pain. And we also saw a significant reduction in the number of days work absent following the intervention. It went from 44 days to 4 days. And patients found their symptoms to be more acceptable to them. The cost outcomes were also interesting. We saw the number of healthcare contacts reduce over the intervention period, and 6 months later, reducing from £312 to £269, and saving 34%. And those direct contacts for low back pain also reduced by 81%. So we're saving well over £200. Analgesic costs reduce, and of those who were taking opiates, 34% stopped their opiates altogether. And we also seen an improvement in the overall quality of life. So what does this study tell us? Well, it's the first study to evaluate CFT in people with health inequalities and those affected by persistent back pain. It was clinically effective, it reduced work absenteeism, and it reduced health utilisation costs. I'd like to thank the team involved with this and also the communities that we engaged with to help co-design our resources for our patients. The QR code there will give you access to some of these resources. They're available in up to 80 languages. Thank you for listening.
Thank you very much. Any question from the House?
Perhaps I could start, Chris. I wonder whether you had any sense of what the difference was. And I understand you were just looking at this population, but do you have a sense of the difference in the outcomes compared for this population compared to other studies that have explored the effectiveness of CFT?
Yeah, so that's a really good question. And so the feasibility work that I did for my PhD, we used an inner city population in Leicester. And essentially, like if you look at the baseline data for this study, baseline RMDQ, high pain levels, they were quite similar. So in the previous study in Leicester, it was baseline disability using the Oswestry Disability Index, and we saw similar levels of high levels of disability and pain, and similar shifts in terms of reductions in those over time.
Brilliant. Thank you.
Thank you.
If there is no other question, we'll move on. Thank you very much.
Thank you.
So we'll move to Ahmed Hassan. The first one is gender differences in outcome in patients treated for thoracolumbar burst fracture without neurological deficit.
Thank you. My name is Ahmed Hassan. I'm a spine surgery fellow at the Center of Spinal Studies and Surgery at Nottingham University Hospital, and I'm an associate member of the AO Spine Knowledge Forum Trauma and Infection, and I'm presenting the work of our Knowledge Forum on the gender difference in outcomes in patients treated for thoracolumbar burst fractures. This is my conflict of interest disclosure. So, as a background, there is the investigations on the relationship between genders and outcome after spinal surgeries produced mixed results, with around 75% of the study shows influence of gender on the postoperative outcome, with only 6.3% of these studies focusing only in spinal trauma. So the outcome from these studies generally reported that females usually report more disability after the same spinal procedures. So the objectives of this study was to explore gender differences and to optimize like a personalized treatment strategy. So the primary goal of the study was to the primary outcome was reaching the MCID in the ODI score and reaching difference in the minimal disability over ODI less than 20 points. We utilized the data that from the AO spine thoracolumbar A3, A4 study, which is a multi-center study that I will present the results of the main study in the next presentation. And regarding the result of this study while comparing male and female participants, they were equal in their baseline characteristics regarding the fracture patterns and the treatment modalities. However, when it comes to achieving the MCID in the ODI in the surgically treated patients, females showed a statistically faster achievement of the MCID in the ODI compared to males, which was 14 days compared to 28 days in male participants. However, in non-operatively treated patients, females showed a trend toward a slower achievement of the MCID with an ODI, the MCID of the ODI reached in 31 days in comparison to 23 days. The same also applies when comparing surgically treated patients to conservatively treated patients. Surgically treated patients reached the MCID of the ODI in 14 days compared to 31 days. And the same also applies to the time to achieve minimal disability, which is an ODI of less than 20 points. So also in the secondary endpoints, although there is no statistically significant differences between the two groups, however, females usually show more anxiety and depression at the point of discharge from the study and at 6 months. And also they reported higher pain levels at 6 months, which usually then equalizes on both groups. So as a summary of the findings, females seem to do worse with non-operative treatment compared to males in thoracolumbar burst fractures, and surgery treated females seem to do better than surgically treated males. Why this is meaningful? So this is the largest and the only prospectively controlled data assessing gender differences in traumatic spinal injuries, and the first study to assess gender differences in non-operative treatment. This will help to shed light in managing these types of fractures, and also additional insight into proposing a personalized treatment strategy, and also provide more information and possibility for more research into gender-related differences in psychometric properties analysis, especially in outcome measures like the ODI. Thank you.
Questions, thank you.
Sorry, this is interesting. Did you have a hypothesis why there would be a difference based on gender?
Because yes, in the majority, in the most of the studies that were studying the post-operative outcomes, especially in spinal surgeries, most of them reported females showed lower post-operative outcomes in PROMs, in patient-reported outcome measures, compared to males. So this is the hypothesis.
Why? Why would gender make a difference? I mean, they have got the same injury, the same treatment. Why would gender make a difference? Did you have a hypothesis? That was my question. Do you know why? Or did you have a hypothesis?
So personally, I don't know.
Yeah, I mean, did you think anything
Sorry?
After the study, when you got the result,
Yes.
did you find anything specific which could make the female worse?
The outcome, so it's a multi-center study, so we generally we found that usually females are offered more conservative treatment based on this previous findings. So our findings are contradicted to the normal belief that we find in comparison to other spinal surgeries.
Okay, thank you.
And we have Ahmed presenting for a second time surgical versus non-surgical treatment of thoracolumbar burst fractures in neurologically intact patients.
So this is the findings from the main study. So I'm just going to skim through them, same thing. So for introduction, burst fracture in neurologically intact patients account for 45% of all thoracolumbar fractures. Both surgical and non-surgical treatment strategies can be offered in those types of fracture, and no one of them is considered to be superior to the other. The main aim of the study to compare surgical and non-surgical treatment for neurologically intact patient for A3 and A4 spinal fractures. The hypothesis that a surgically treated patient should have a clinically relevant improvement in ODI shorter than the non-surgically treated patients. So this is a multi-center study. We included patients from 18 to 65 years of age suffering from A3 and A4 thoracolumbar fractures. Only neurologically intact patients. The exclusion criteria, we excluded pathological fractures, polytraumatized patient, and previous spine surgery. The same study outcomes, which is the primary outcome reaching and the MCID of the ODI, and difference in term reaching the minimal disability, which is an ODI of less than 20 points. The study was conducted starting from 2017 with 14 hospitals in 10 countries. As a conclusion, both surgically and non-surgically treated patients, there was no significant, statistically significant difference in reaching their ODI, either reaching the MCID of the ODI or reaching the level of minimal disability. However, what we noticed that there is an 13-day difference favoring surgical treatment in achieving the MCID of the ODI, and also there's a 26-day difference with earlier return to work for surgically treated patients. So in conclusion, both surgically and conservatively treated patients do not differ in ODI improvement. More rapid improvement can be observed in surgically treated patients, and patients who are valuing more rapid recovery might opt for surgery. Other factors may play a role in surgical decision making, like health economic analysis, which shows that on the long run, surgical treatment in this type of fracture is considered to be a more cost-effective option compared to conservatively treated patients. Thank you.
Thank you very much. Any question? While people are thinking, if there is not much difference, the analogy is like a lumbar microdiscectomy. In 3 years, 4 years, you treat surgically or don't treat surgically.
Yes, yes, for the acute component of the fracture, yes, it's similar to a microdiscectomy. So all patients tend to improve. The concept of developing the only thing is the developing of post-traumatic kyphosis, which is not that common, especially the younger the patients get, the possibility of developing post-traumatic kyphosis is less than the older population.
But obviously we'll need much more stringent follow-up with imaging in case of conservative management.
Yes.
So it will be worth looking into the economic side.
Yeah. So I presented the results from the health economic analysis yesterday. So on the long run, on the 2-year health economic analysis, surgical treatment was more cost effective because taking in consideration days absent from work, lost productivity, and like, for example, the cost of braces and all of this is put in at 2 years. It's more cost effective to do the surgery compared to the conservative treatment.
Were there any surgical complications?
Sorry?
Were there any surgical complications?
In the study, yes, mainly surgical sites infection. I can't remember the exact numbers. Mainly surgical site infection and implant failure for surgically treated patients.
I suppose that was taken into consideration.
That was taken in consideration for the health economic analysis. I know.
Thank you for your talk. Really should have been a question that I asked for on your first one, but I noted that you had quite high caregiver costs in the non-surgical arm versus you didn't have any in the surgical arm.
Sorry.
So vice versa. So you had high costs in
the higher cost in the non-surgical.
In the caregiver. Could you just explain what those caregiver costs were and why they weren't in the other arm?
So for in the non-surgical patients, the higher cost mainly was calculated on the days lost from work days absent from work and lost productivity, and also mainly the cost of physiotherapy sessions and the brace. This is for the 2 years. And for the 2 years after the immediate 2 years. And after this, it was the health economic analysis predicted that there is a $28,000 per year lost in productivity in non-surgically treated patients. The main cost in the surgical arm was mainly the cost of the surgery itself. However, the opioid use, for example, physiotherapy and days lost from work was much less in the surgical arm compared to the non-surgical arm.
Okay, last question.
Yes, Miltiadis Georgiopoulos, spinal surgeon in Swansea. Regarding, not specifically only for this abstract, but from this study, have you seen any difference regarding the rates of neurologic deficits between the surgically treated and conservatively treated patients? They didn't have neurologic deficits in the beginning, but their appearance after, either as a complication of surgery or as a complication of conservative treatment, for example, because of the worsening kyphosis of the spine. Did you see any difference between the neurologic deficits between the two populations?
No,
and
actually in the conservative arm, none developed neurological deficit in the conservative arm. In the surgically treated arms, there were some cases not some cases, I mean less than 5 cases, I can't remember the exact number, but less than 5 cases who developed radicular neurological deficit, mainly of mal-placed screws.
Do you remember what percentage was that?
Less than 5, I can't remember the exact percent, but less than 5 cases from the 130 cases who were surgically treated.
And in terms of
Sorry, just in the interest of time, we need to stop there. Thank you very much.
Thank you. Okay. Thank you. So we'll move to the last paper of this session. Lucidov, Measuring and Understanding the Sciatica and Leg Weakness Study, a Scoping Review.
Thank you. Good afternoon. I'm Lucy. I'm a PhD student in clinical neurosciences at Oxford University, and I'm here to talk about my project, which seeks to understand and characterize the leg weakness profile in people with sciatica. I'd like to acknowledge funding from the NIHR and from Oxford BRC, who've funded this doctoral project and some pre-doctoral work also, but no other conflicts of interest to declare. So the project has 4 parts to it, and today I'm going to focus on the scoping review, which simply seeks to understand what measures exist. How can we look at leg weakness in people with sciatica? And I'll give you a little bit of background to the genesis of this idea. Back in 2020, I was working as a spinal physiotherapist in a surgical service, and COVID happened, and we all had to do our assessments by video or telephone consult. So without the ability to assess patients in person, we had to ask them over the telephone, do you have weakness in your leg? And the resounding answer was yes. So we would get these patients in to assess them clinically, and invariably when we brought them into the hospital and did our manual muscle test, our scale from 0 to 5, we would find no weakness. And I learned to understand that this was not a problem. We move on with it. They don't have weakness in their leg. But it left me uncomfortable. Patients were reporting a symptom that was not being detected with clinical measures that we had available. So I looked into this a bit more deeply, and we were lucky enough to have some data in our clinical service. So I looked at the Sciatica Bothersomeness Index, which has a subscale for weakness, and compared it with the MRC scale, and found that indeed there was a big discrepancy between reported and observed measures of leg weakness. So 85% of people are reporting leg weakness, but only 34% of them had positive clinical signs. And age and leg pain were possible mediators of the difference between these. And I'm not the only one to pick up this difference. Longitudinal cohort studies have identified high numbers of people with leg weakness 2 years after the onset of their symptoms. So it's a sizable problem and it's a long-term problem. So back to my scoping review, we included patients who had a clinical diagnosis of sciatica and where there was a measure carried out of leg weakness. We excluded animal studies, we excluded measures of the upper limb, we excluded peripheral neuropathies where there had been insult or trauma to the nerve peripherally, and where the measure hadn't been described in enough detail to extract information from it. We also excluded studies that had only looked at the MRC scale in isolation. There were over 6,000 records identified through database searches, and we've whittled it down to 77 studies so far. So, the observed measures. How many observed measures do you think we found in those 77 studies? There were 83 separate reports of observed measures in the studies, and I'll show them to you now. So there were a sizable number that would come under the broad category of electrodiagnostic study, be that EMG or nerve conduction studies were the main ones. There were also a lot of studies looking at cross-sectional area of multifidus, psoas, erector spinae muscles on MRI scan or ultrasound imaging. There was a lonely gene expression study. And more towards the clinical side of things, there were functional tests that the physiotherapists in the room will be familiar with: standing on tiptoes, standing on heels, sit to stand, timed up and go tests. And then there were tests that brought in some aspect of technology, such as handheld dynamometry. There were isometric tests as well, motion capture studies, and simply observation of muscle atrophy. Surprisingly, only 2 studies mentioned it. Then in contrast, the reported measures were much fewer. Only 24 studies looked at reported measures, and the vast majority of those came under the bracket of physical function. So the SF36 has a subscale for physical function, and I think 9 of these studies were that measure. Weakness was specifically looked at in 8 studies, and most of these were the sciatica bothersome or sciatica frequency index, which is well validated for this patient population. Also, ability to walk, and a pain questionnaire that looked at tiring or exhausting symptoms. In summary, please consider asking your patients if they have leg weakness when they present to you with sciatica. If nothing else, it might validate the symptoms that they have that are important. And we've heard how important that is this week. Consider measuring it. The Sciatica Bothersome Index is an ideal measure. It's very quick, it's been well validated, and it's available in multiple languages. And I'd just like to sow the seed that if we're not detecting this, then we're certainly not rehabilitating it. I got ethics approval for this survey yesterday. So hot off the press, if you'd like to take part, please scan the QR code. I'm interested in any health professional who sees patients with sciatica. I want to know how you measure it, and it won't take much of your time, I promise. I'd like to thank the team that I'm a part of, and my supervisors, and to Carl, who's spent long hours screening studies with me. I'm very grateful. I'd like to acknowledge Laura Bassi, whose website address is at the bottom there. She's designed the logo for the study, which is fantastic. And I will leave it on that slide in case you'd like to take part in the study. Thank you.
Can I invite questions, please? Thank you. Perhaps I could start, Lucy. I wondered what you were going to do with that information in the next stages of your PhD.
Thank you. That's a great question. So the next stage is to take those measures to qualitative interview study with patients. So obviously I'll take that with the survey data that you provide, and over the next few months I'll gather that survey data, and then I'll take it to patients and I'll put it to them. Do you think this is representing the symptoms that you're having? And that will form part of those interview studies. And then from that, we'll put that into the final profiling study to be able to really deeply phenotype and understand these patients much better.
Thank you. And any other questions, please?
while people are thinking, I mean, this is a common phenomenon, isn't it? If you ask a patient with acute pain in the leg, sciatica, they will say, I have weakness. But when we actually examine objectively, there is no weakness. So even when we document as pain-related weakness, which is actually not a true weakness.
Yes, and I think pain is going to be an important covariate. I think for that reason, we might avoid recruiting people in the very acute stages of sciatica and look more towards those chronic patients where we know this is a symptom that persists, yet is not successfully treated. Yeah.
Thank you. Apraju Ulash from Preston. Means MRC grading, means the way we test in the clinics is very crude. It's not sensitive enough to pick up the weakness that patient is feeling. And, and also sometimes you have patients who come in and you ask them those functional tests, that it becomes apparent that they have got a problem. So I think some of the discrepancies between what patient is reporting and what you are finding, and the truth is somewhere in between, because they do have some weakness. And sometimes it progresses, sometimes pain makes it worse. But I think we have to be in clinical assessment a bit more careful and perhaps document it in more carefully how it was tested. Then perhaps will give you the real where we are.
I agree with you completely. I think the MRC scale is a very crude tool to do something that particularly it might be quite nuanced for us to look at. And that's why we will look in more detail with that profiling study. I've got force plates, I've got body-worn sensors, we're going to look at postural sway, so we will be able to characterize it much more deeply than we currently have with the MRC scale. And maybe we'll find some proxy measures that we can then go, okay, this subgroup is identified with this clinically useful measure, and we would be able to move from there.
But then problem would be to bring all those fancy things into the clinic to test.
And I think we'll need to end it there. That's the end of our session. So if you could pick that up later.
Yeah.
Very quick. How many of your patients had hip or knee pathology?
Hip or knee pathology?
Yeah, confounding
in
variables.
In these studies?
Did you pick up any that had hip or knee pathology as well as sciatica?
No, they would be excluded from the studies. Right. No.
Thank you.
Thanks.
And thank you. Can we give a huge round of applause to all our speakers? Thank you.
Afternoon, everybody. If we could take our seats for the next session. Thank you all for coming. I'd like to welcome to the stage Jonathan Hearsey, who's going to talk to us about his experiences of co-construction and the opportunities for MSK services in ICBs.
Thank you very much. Good afternoon. I expected about 5 people here, so you're far more than I thought. Who wants to hear about ICBs? However, my name's Jonathan Hearsey. I'm Clinical Director for Camden MSK. Camden MSK is an interface service in Camden. When I got on the train to come from London to Manchester, I also had a job with the ICB. Obviously, when I get off the train in London, I'm not sure about that job with the ICB at the moment, so go easy on me if you can, because I might be looking for work. Got a clear agenda today, so 3 things I want to talk about. So co-construction initially. I then want to talk to you about what we've been doing in the ICB in North Central London, so that's NCL, and then how it is relevant to your work in spinal MSK, and that's right across the patch. So in terms of co-construction, what is co-construction? So really clearly, co-construction is to do with the development of the system and policy. Okay, so it's the main structure. It's designing services with stakeholders and so with them and for them. And it's very, very marked in what we can do around co-construction. So it's a proper led, usually almost certainly needs to be led by an organisation of some kind. So either a trust or the ICB themselves. It's formalised and it's structured. And it's outcome focused. Now that's not necessarily clinically outcome focused, it can be financially outcome focused too. But the whole point is it's a structured, organised way of developing services. How does co-construction differ from co-production? So co-production is much softer, if you like, and it's much more around equal partnership with patients usually. Patients are involved in both, but certainly it's around the softer, fluid service development elements. Okay, so it's about improving experience, and it's process focused still, but it's about the experience that those patients have. So the opportunities for ICB. So clearly, there's an opportunity here for strategic leadership. So it drives that system-wide change through collaboration. It gives the opportunity to fully reflect on your own pathways and the pathways that you've got throughout whichever sector you're working. It has benefits towards the workforce themselves. So in terms of development, it can support advanced practice, career development, but also making sure that the people actually are doing the jobs that they're designed to do and that they're trained to do. It has enormous wealth from an ICB point of view in looking at values and value-based commissioning. So that's not just about value for money, although that is a factor, but it's around a shift towards effective practice and getting it right first time, and all the things that we know that are kind of in the lexicon at the moment, but certainly it drives that commissioning structure. And it's regarding patient investment too. So in terms of, by patient investment, we mean education and the understanding of when you need to present and who you need to present to, and also those self-management elements of the work that we do. So how do you implement co-construction? So it's really clear that it needs thorough engagement. The term stakeholder I absolutely hate, but I can't find another word for stakeholder, so we're going to have to stick with stakeholder, I'm afraid. But it's about engaging those stakeholders, and every single stakeholder. So it's about asking everybody. It's about gathering insights. It's about using the data that we get from the services that we offer, but also from patient feedback and from feedback from our clinical staff and our non-clinical staff too. It's about the thorough assessment of our pathways. Are our pathways evidence-based? Or are they just something that we habitually do? Any work to implement any new structure needs piloting. And I've heard loads over the last couple of days around really good, well-researched projects. But there was a question yesterday from I believe, a colleague of the person presenting. And it said, well, what are you going to do when you leave my firm? How are you going to implement that? And there's a degree of transaction that needs to be done from the work that you're doing in this kind of academic forum to getting it into the position where it can actually be actioned and transacted. And also there needs to be an opportunity you need to measure everything, and it also needs to be adaptive. So anything that you do, anything that you change needs to be adapted and adaptable. Now, in terms of potential obstacles, there are 5 main obstacles, really, and we've all been in those meetings with commissioners or with managers, and there is always, usually just one person, we all know who that person is. And one of those, the questions usually from the same voice is, to me particularly, and I've heard this many times, who the hell do you think you are? How dare you come to my service? And who gives you the authority to look at our service? And on the subject of authority, the solution to overcoming that is to gain a mandate for what you're doing. It doesn't necessarily mean permission, but it needs an actual mandate. So allowing yourself to feel supported in the work that you're going to do. So it's challenging. Now, usually from that same person, if you give them the answer around authority, they may turn around and say, well, we haven't got the staff to do this. We just haven't got the staff, or we haven't got the money. Now, you've heard these before. If you haven't heard them before, it might be you that says it. There are issues, though. And so there are funding constraints. We all know. The news we've had today and what we've been hearing the last couple of days, it's quite abhorrent to those of us that are working in the system. How are we going to, the pressures that all the trusts are under at the moment, we've been paid too much, we've got to do more with less staff and less money. And that's going to be very difficult. And there are system changes as well, and there are system issues. So around data systems and how things interact, that is a real problem. And at the moment, we haven't really got the answers. And Wes Streeting was being questioned today, and he was coming up with, we know that there are IT issues. We know there are system issues. So, North Central London. The MSK review that we did So what was it? The current provision, firstly, in North Central London. So North Central London is made up of 5 clinical boroughs, or five geographical boroughs. We have 4 acute hospitals. There's a +1 there too, because we've got 1 hospital that is contractually and financially in North Central London, but it actually geographically sits outside of North Central London. We've got 4 MSK community providers, which gives us 4 silos. Now remember, silos aren't necessarily bad, but they can become quite difficult. The main issue with those siloed community MSK providers is that there's a mixed structure. So right across the whole of the 5 boroughs, there's a mixed structure, and there's a massively different commissioning and funding model. So already we're on the back foot. So we can't have, so for those 5 hospitals, we can't have a clear route of referral into those hospitals because we've got a mixed structure in the community. So it's interface services like mine, which has been completely redesigned. It's really clear. I know how much it is, I know how many patients come in, I know where they go, there's a robust pathway, and it's very, very clear. But if you haven't got that and your community service, that interface service has evolved in a certain way, then GPs game the system for the right reason, but physios game the system, imaging is quite difficult. So it all gets thrown in the air and there's not much of a structure and it becomes quite difficult. So what was the review? So it was system-led and it came through the orthopedic network. So initially it was a conversation I had with one of the CEOs about my knowledge of what was happening in the 5 boroughs. And so we put together a plan to recruit somebody, I didn't realise at the time it was going to be me, to recruit somebody into the ICB to assess and to lead the clinical review of all of the services. But because it was an ICB-led thing, we also got a programme team to do it. So we've got a team of programme managers, but we also got a team of analysts and public health consultants that came with it because there was a drive to actually assess what was going on. So it was mandated by these CEOs. So we presented at the provider collaborative and we said, this is what we plan on doing. Not necessarily can we have your permission because we should do it anyway, but can we go out and talk to your staff and tell them that you know about this and really ask their opinion and see what's going on, which was granted. The review itself was informed by primary care data, but also we used population health and public health data as well. So it was truly co-constructed. Now we did it in what we were very cute with. So initially we got the program team together, but we weren't really sure how to go about this because we having been clinical previously myself, I didn't quite like the approach to commissioning previously, which is a group of men in a room with a computer, tell us how to see patients, and then that comes presented to us and say, you will now do it this way. And that didn't seem right. So the first thing that we did was we engaged with our stakeholders. We went to them all and we said, how does it feel? We mapped the clinical services. So we looked at absolutely everything. We benchmarked the services. We did something called bottom-up baselining, which is we approached the CFOs initially and said, how much does your MSK department cost? How much does it cost in the community? And CFOs didn't necessarily understand that question. They certainly couldn't tell us how much it costed. They just knew how many staff they had, how many patients they saw. They didn't have the factual breakdown of what it costs to see a patient in the community. And we use data as intelligence. Now, we all know primary care data is poor and it's difficult to get hold of, but we used the best available data to help stem what we were going to do. So that was how we delivered it. But the first thing we did, which is you must dare to ask. So we just went out to everybody. We went to administrators, we went to patient groups, we went to interest groups, we went to all the clinical staff, all of the networks, and we said, what's it like? Tell us what it's like at the coalface. And it was abhorrent, really, to hear what they told us. It was the things that you might be familiar with, unmanageable workload, failing patients. So certain cohorts of patients we were definitely failing. But they felt that there was widespread inequity. They felt that we were perhaps presenting care in the wrong place and providing care in the wrong place, but also failing to educate patients and failing to get that buy-in that we need in non-surgical, non-medical MSK complaints. So we dared to ask. So that's a true systems thinking approach to healthcare. So what did we learn? So we took what we learned from these groups, and then we went back to the data analysts and to the public health consultants and said, well, that's what they've told us. Let's look at all the data. And so they poured through all the data for us. And again, the benefit of co-construction in this way is that everybody gets the buy-in. So you get to speak to everybody. Everybody's got a vested interest in making this work. So, of course, they showed that we had, in the years that we looked at, they showed we had increasing demand to the tune of 10%. So we were getting 10% more referrals in that year than we did the previous years. And we were able to then look at what it was going to do for the next few years going forwards. We knew that there were health inequalities. We knew we were failing those that were out of work, that weren't exercising, that were obese. We knew we would fail those that lived in poverty or those that were smoking. This was current with what we knew in nationally. But also we could clearly find there was inequity of funding, inequity of access, inequity of provision. We had it in Camden, in our community pain service, we've got dietitians, or we had dietitians. In Barnet, they don't have a community pain service. So if you've got a chronic condition and you live in Barnet, you have access to nothing. If you live in Camden, we've got dietitians looking at lifestyle medicine. We've got anaesthetists that are involved in different pillars of health. So it's completely unfair in the same sector. We knew there was care in the wrong place, and we were able to evidence this as well. Now, there are alarming things here, and the data is, if you scratch it too hard, it might erode. But what we were able to see was 20%, just under 20%, 25% of our our new patients, consultations in the acute sector, so with orthopedics, neurosurgery, rheumatology, 25% had no near-term follow-up within 12 months as an inpatient or 18 months as an outpatient. So again, we went to those services and said, how does that feel? 1 in 4 of your patients, do you do anything with? And they'd come back and say, that feels about right. And they were able to list as to why it was right as well, because the GP sent it to me for an MRI scan where it should have gone to physio, or it should have gone somewhere else. So these kind of erroneous referrals were coming through to the system. We also weren't doing enough about prevention and early detection. So the government are now asking us to look at these 3 big shifts. One of those is around digital, obviously, and one of those is around prevention and early detection. And we clearly knew we weren't doing that. So while some of us are starting to use Get You Better in the community, others aren't using it properly or are using it differently, and some don't have those services at all. So obviously the news today is a bit different, and this slide is maybe completely useless. I hoped when I was asked to come and speak, I hoped that this service would all be run now and we would be procured, and I hoped I'd lead it, and I hope we'd be moving forwards. Unfortunately, we were, as of yesterday, just about to go to open and competitive procurement, which is fair. We can't get around that, and that's the law. We have to do that, and that's fine. And what we were hoping to just about procure is an oversight, so a lead provider to come in and to form an oversight and improvement organisation. So they would work, think of it as kind of clinical management consultancy. They would come in, it will be a trust or an external provider, come in and oversee the existing provision. What they would also do is work with the teams, because we've done the legwork already, so we've got care pathways that have been agreed. But we will go and really drill down to those care pathways for the whole sector, for the whole of the 1.6 million residents in North Central London. We were going to look at smoothing out access and referral. We were going to make sure that there was a central hub, not a clinical single point of access, but a single point of access for all referrals. So we could have a data hub, so we could have a governance hub, so we could make sure that everything that came through was counted. And we've formed care pathways with our teams, truly co-constructed, formed care pathways to work this way out. But we will be working with existing providers. So no one loses their jobs, possibly me, but no one else will lose their jobs. But it will work with existing providers, but all working to the same set of governance and the same set of rules. So, how does it affect you? How does what I've told you and what we've done in North Central London affect you? Firstly, someone can say it, who the hell do I think I am? I can't tell you what's wrong with your service, okay? But I can guess, okay? Now, you might have nailed this. Your area of the country and your area of spinal MSK may have nailed this. But I'm expecting some of you to feel the pinch around inefficient referrals. So some of those referrals that come to you, you think, I don't quite know why that patient's here. I've got a duty of care to that patient, but they're here, they need something else. I wonder whether there is inappropriate ED use. So the simple things, those urgent patients, they're not emergency patients, but they're urgent, they need to be seen quickly. I bet you they're ending up at ED. And if they end up at ED, they're going to come round to another service, perhaps secondarily, that maybe don't need to be there. So again, the pathway is incorrect. I would assume you've got a few disparities around triage. Again, departments being overloaded, some areas working too hard on some departments, and some areas not working hard as they perhaps could, or taking on stuff that they shouldn't. And that there will certainly be some resource gaps. And I'm sure that if you were able to stand in primary care and say, I know exactly what to do with that patient with spinal stenosis, for example, I bet you not all your GPs in your area, all of your referrers, know exactly where to send that patient. So from a communication point of view, they probably don't have sight of the site of the referral or the site of where that patient might be. So the benefits of co-constructing or transforming your services. So who benefits from a well-designed and efficient service? So the first thing is patients, obviously. You will benefit as a clinician, as an administrator, as a general manager, as an accountant, as a business partner that works in HR. If the system is running properly, the workforce will benefit. Okay? You as clinicians, but the workforce generally will benefit from an efficient service. The system benefits. So if we've got MSK sorted out, then there's space in ED for the patients that need to go to ED. There's space in primary care. There's a big contentious issue around, it's been quite interesting to watch the battles around MRI scan in the last couple of days. And it's really interesting. And you can choose which side you want to be on. My service serves 40 grand a month by not allowing our GPs to do MRI scans or MSK MRI scans. Okay? And that funds our service. We can't get away from that. But there are ways of improving that too. But the system will benefit. And finally, the economy will benefit. And that's all the changes today to the NHS, to making people work, to getting people back at work. The economy will benefit from the work that we do, from any transformation that you do. So when I'm king, I want a true kind of shared purpose. Okay, so my dream for your services, okay, you all know what you're doing, and then you all trust what other people are doing. So you've got that kind of understanding of they're doing that really well, I'll do my bit really well, okay, and we're all accountable. So we all know when those patients are being seen, we all know where they're being seen, we all know how much it's costing, okay. We won't talk about PLIX data, but next time you meet one of your accountants at work, ask them about PLIX. It's really interesting. So is co-construction the key to transformation? No. You are. It's merely a vehicle. Okay? It's a way of doing things properly. Now, I'm acutely aware that this is an academic conference, and I've given you next to no data, and this is all anecdotal. Okay? But I think I do this for a living. And I really want to, my sort of call to action is just ask. You're not doing anything wrong. But you must move forwards and do this, and that's how you improve your services. Identify your priorities. Identify your local priorities. What matters to you and your punters? It's really important. Gain a mandate. Don't necessarily ask for permission. If you go and ask a CEO for permission, they tend to say no. Worse, they may say maybe, but they tend to go no first up. But say you want to do this work, I'm really interested in doing this work, and collaborate. Collaborate the hell out of it. Engage. Talk to anyone that will listen. Talk to anyone that won't listen. Just keep going on. Okay? Start small. Do a pilot. And then build. Build on that. Assess. The more reflective you are, the more effective you are. So just keep pushing, keep challenging, and then you can scale. And gradually you can get this thing to sort out your whole service. It's really, really important that you just test it, that you're adaptable. Consciously, there are no logos, and this is my only photo on the slide deck. Those that you will know, that is Ai Weiwei's sunflower seeds in the turbine hall. And it sings to me that they all look the same. All of those sunflowers, millions of them look the same. But they were all individually handcrafted in ceramic. So whilst they all look the same, they're all entirely different. They're all absolutely unique. I've got some at home because my 8-year-old nicked some, but that's another story. It's been a pleasure to speak to you. I genuinely mean this. Ask me later, ask me now, have some questions. Don't ask me who the hell I am. But do email me if you've got any questions. I am currently paid to do this, and I do a lot of work nationally as well. Part of my appraisal is to go and speak to other people around it, which is why I'm here. But do please email me and discuss it if you've got any questions. Thank you.
Thanks, Jonathan. That was magnificent. Has anybody got any questions? Perhaps while you're collecting your thoughts, I'll ask one. You listed the benefits, which was great. And I sat here and thought, that sounds like a sales pitch. And I think most people in this room have been around long enough to see service re-evaluation time and time and time again. And you have been extraordinarily close to this. I'm completely removed from it. I don't understand any of the words, any of the systems, any of the data. So can you convince me this is going to do anything better than promise us jam tomorrow? Is this really going to make the world better for us all, or is it just another re-evaluation, present another service, and in 5 years or 10 years we'll be re-evaluating again?
I think that the difference is the way you go about it, and I think it's previously, and again, you know, I've got colleagues in the room that when I was clinical, it just felt like I was being done to. You know, yeah. I would turn up at work and there would be another screen and another computer, and they'll say, by the way, can you get this data? Actually, someone in the room, we were enforced to get the data because we couldn't save System 1 notes. We couldn't save out of the record until we asked the questions. And it's, you know, things like that. And it didn't feel right. And the other thing is co-production is, I'm talking about co-construction. And co-production, I think, has failed. It seems to be box ticking, engage patients. You know, you end up engaging patient interest groups which have no knowledge about anything else other than the patients they've got. So this is a much more structured version, a much more physical version of doing stuff. But it will only work if you start with the engagement from the people that are actually doing it. So I think that's the only difference. Because you're right, it does, you know, it sounds normal. It sounds like I'm just a manager, just doing managerial shit. and that's, sorry, since I shouldn't say shit, should I? Could have said fuck. Anyway, so yeah, I know what you're saying, but I think generally, if we're all doing it and we're all engaged, and it is facilitated and it is supported. I heard a phrase this morning actually, where someone was saying, "I don't know when to send that through to the surgeons," and that's the worst phrase I've heard in the last couple of days. It was that. Why sending it through? Why are you not all in the same team? You know, it's like if that needs to go through to the surgeon, then surely it should have been with the surgeon in the first instance. And if you're the blockage in that pipe because you're seeing that patient, you know, see what I'm saying? And it must, if you're there with the surgeons, then you understand it and you're working together. And I think, you know, if you're working separately, there is a problem here. So that's my continuing to sell it.
Spoken like a true manager.
Yeah.
The question.
Yes, I would ask my first one because it's already been covered. Along your similar lines, I was going to say, why is this not another box-ticking exercise? I wouldn't repeat that.
I couldn't hear.
Why is not co-construction another box-ticking exercise? Same cynicism. I think you understand that.
Yeah.
So I'll skip that one because it's covered. Yeah. Next to the cheeky question. In your experience in this stuff, where have you seen most of the blockage? Was it in the secondary care clinicians? Was it in primary care clinicians, or was it somewhere in the middle?
Okay, realistically, it's the managers. It's the 8A, 8B managers that have been It's the bit that we probably could cull. You meet your mates down the pub and they say, NHS is failing because there's all those terrible managers. It's the terrible managers that don't like the change. The clinicians, I mean, I work with Jim and some of Jim's neurosurgical mates, and they have been so open, so giving. You know, it's like, good, do something. I think there is a problem with some issues. So in Camden, we take the budget for rheumatology, neurosurgery, and orthopedics. So things like fibromyalgia, for example, there are some rheumatologists saying you must, you know, only diagnosis from rheumatology. That's ridiculous. You know, you're going to have to let go of stuff. You can't see everybody. And I think that's where the workforce changes make. But actually the resistance is coming from the kind of change-resistant people that just don't like it. We do it, you know, busy being busy. You know, how's work? Really busy. You know, they're the people that are the change-resistant ones. Or the ones that say, I need more staff. I can guarantee, I can ask any of your managers, do you need more staff? They'll all say, yeah, I need 3 band A's, 8 A's, I need a band 3 and a band 4. They know that instantly, but let's do it differently. So that's the selling point there, is we need to work differently.
Any other questions, or shall we bring this to a close? Okay, brilliant. Thanks once again, Jonathan.
Thank you.